Assalamu alaikum wa rahmatullahi wa barakatuhu. Hi guys, this is Shahadat and today I'm going to read from a scientific paper for you. This particular paper was published in open access journals.com and it was published in the diabetes management section. The title of this paper says, or it's a case report rather, it says a clinician's guide to inpatient low carbohydrate diets for remission of type 2 diabetes toward a standard of care protocol. This paper was published or authored by Mark Kukuzala, Adel Haidt, Caitlin Peterson, Laura Saslow, and Rory Heath. This is the second part of this video. In the first part, I've read the abstract and the introduction part. And in the second part, I'm going to start from defining carbohydrate reduction. So without further ado, let's start. Defining carbohydrate reduction. Dietary carbohydrate reduction can take many forms. More precise definitions for the variety of therapeutic approaches that carbohydrate reduction represent are needed. The following levels of carbohydrate reduction are based on protocols currently in use and on definition found in the literature. VLCK, or very low carbohydrate ketogenic diets, recommend 30 gram or less of dietary carbohydrate per day, reference 10. Restriction of kilocalorie or kcal is not typically recommended. LCK, low carbohydrate ketogenic, LCK or low carbohydrate ketogenic diets recommend 30 to 50 gram of dietary carbohydrates per day, reference 22. Sometimes net carbs calculated by total carbohydrate minus fiber will be used with a goal of 25 to 30 gram net carbs per day. Restrictions of kcals or kilocalories is not typically recommended. RC or reduced carbohydrate diets recommend at least 50 gram but less than 130 gram of dietary carbohydrate per day, a level that is higher than therapeutic levels listed above and lower than the US Institute of Medicine Dietary Reference Intake DRI for carbohydrate, reference 23. Restrictions of kilocalories or kcals may or may not be recommended at this level. MCCR, moderate carbohydrate calorie restricted diets recommend more than 130 grams of dietary carbohydrate per day with a range of 45 to 65% of daily kcals coming from carbohydrates, reference 22. In most cases, kcals are also restricted to maintain energy balance or to achieve a deficient for weight loss. This dietary intervention reflects the amount of dietary carbohydrate typically found in the carbohydrate counting dietary interventions that is given to many people with T2DM. Although this article follows common practice in using the term low carbohydrate diet to refer to a variety of carbohydrate reduction therapies implemented in clinical setting that fall below 130 gram of dietary carbohydrate per day, the specific protocol under discussion here is LCK diet or low carbohydrate ketogenic diet. Clinicians should note that other interventions for remission of T2DM such as very low calorie diets or intermittent fasting effectively reduce carbohydrate intake as part of overall kcal reduction. Conversely, reducing carbohydrate intake in practice often serves to reduce overall kcal. Recommendations for kcal restriction or calorie counting are not typically part of VLCK and LCK clinical interventions, but may be used in research protocols. Next section, therapeutic potential in T2DM. The pathogenesis of T2DM is of progressive insulin resistance to which the body responds with increased insulin secretion. Consequent hyperinsulinemia drives glucose and free fatty acids to be stored in adipose tissue, muscle, and visceral organs, which results in continued weight gain, worsening insulin resistance, and dependence on higher circulating insulin levels. Chronic hyperinsulinemia may lead to a beta cell exhaustion and failure of insulin production. Insulin acts as a proliferative signaling molecule, and hyperinsulinemia may contribute to the development of cardiovascular and inflammatory disease. Reference 24 and 25. The hyperglycemia of T2DM occurs when systemic insulin resistance overwhelms the ability of the pancreas to produce an adequate amount of insulin. A low carbohydrate diet limits foods containing starch or sugar to minimize blood glucose excursion and subsequent insulin demands. Thus, the basic mechanism of low carbohydrate diet aims to interrupt the disease progression by maintaining normoglycemia while reducing insulin demand and reducing insulin resistance over time. Low carbohydrate diets typically minimize the requirement for insulin or other hypoglycemic medications. In contrast to pharmacological methods, a low-calorie carbohydrate diet carries lower risk of hypoglycemia and ameliorates the need for progressive increases in pharmacologic therapy. A recent comparison of LCK diet against MCCR diet showed greater weight loss and better glycemic control in those following the LCK at both 6 and 12 months of study. Reference 22. In the aforementioned study, the metabolic benefits were followed by the removal of anti-diabetic medications in the LCK group, but not the MCCR group. The amelioration of metabolic derangement and reduction of dependency upon insulin or other hypoglycemic medications in a number of clinical trials suggests that diabetes is, for some, a reversible condition. Reference 10, 26 through 30. Next section, inpatient protocol. The protocols and resources presented here were discussed and edited by a collaboration of physicians and allied healthcare providers who have experience with utilizing low-carbohydrate therapies in their practices. The pathway for remission of T2DM through the use of LCK dietary intervention has been used for over 3 years at Jefferson Medical Center in West Virginia, a 24-bed critical access hospital affiliated with West Virginia University, or WVU. This small rural hospital serves a county with a population under 100,000 whose health demographics are representative of the state with the highest obesity and diabetes rates in the US. This institutional example demonstrates the successful implementation of therapeutic carbohydrate reduction for T2DM in an inpatient setting. The inpatient setting provides a unique opportunity to implement low carbohydrate approach, although it also includes several challenges for the clinician. Excuse me. An inpatient setting allows a carefully controlled environment in which to change the diet, measure response, and titrate medication appropriately. Through inpatient initiation of therapeutic carbohydrate reduction, a new medication regimen can safely be established before discharge with plans for outpatient follow-up. Specifically, short-acting mealtime insulin dosage can usually be discontinued or dramatically decreased, which also serves as a teaching tool for patients regarding effects of dietary carbohydrate on medication use. The disruption of an inpatient hospitalization can also inspire motivation for long-term behavior change. Furthermore, the inpatient setting benefits from more time to coordinate education and follow-up. Ideally, a multidisciplinary team approach that includes the hospital provider, pharmacy, nursing, dietary, and nutrition services will be appropriately trained and available to collaborate on the implementation of this intervention. This multidisciplinary team can assist in medication management and patient education. Mobilizing an interdisciplinary team approach for education, clinical management, and follow-up has been successfully modeled in the community hospital setting described above. Despite these advantages, there are significant logistical and institutional barriers to widespread use of therapeutic carbohydrate reduction for T2DM in an inpatient setting. First, eligible patients are limited due to the acute nature of short-stay inpatient admissions and tension between addressing acute versus chronic health concerns. Additionally, time and financial costs needed for educating food service staff and administering the diet can be prohibitive in many institutions. Finally, defining recommendations for fat or salt-restricted diets represent an additional regulatory challenge. Many patients are placed on a salt or fat-restricted diet, which contradict the dietary pattern recommended for T2DM remission in this protocol. These challenges require a level of active engagement and excuse me. These challenges require a level of active engagement and critical thinking by the clinician and team. For example, a patient with T2DM hypertension, as HTN, and coronary artery disease, or CAD, would typically be placed on a salt and fat-restricted diet as part of usual care. However, if it seems likely that T2DM is at the root of both of these CAD and HTN, the the clinician would need to prioritize the dietary pattern supporting T2DM remission. Appendix 1, with the title Clinician's Guide to Low Carb Diets, provides a clinician-oriented overview that describes how and why a LCK dietary intervention may be used as a therapy for T2DM. This pamphlet may be used to initiate discussions in hospitals or clinical settings with regard to increasing the opportunities for patients to have the option to reverse T2DM using a low-carbohydrate dietary approach. We describe a 7-stage protocol for implementing a LCK diet in an inpatient setting. This protocol has been successfully used to minimize the requirement for insulin or other hypoglycemic medications and to normalize markers of T2DM. This indicates the potential for providing clinicians with the opportunity to help patients reverse T2DM rather than just manage its progression. The 7-stage protocol consists of number 1, patient selection, number 2, pre-diet evaluation and counseling, number 3, patient education, number 4, initiating the dietary intervention, number 5, managing medication changes, number 6, addressing any side effects, and number 7, follow-up. It should be noted that similar methods for treating T2DM with a low-carbohydrate dietary intervention have been implemented globally in a variety of settings. The authors are familiar with the clinical applications of low-carbohydrate diets in multiple primary care practices in the US, UK, and Canada. Furthermore, the value of reducing carbohydrate load in the diets of those with T2DM has been recognized for over a decade, and numerous clinical trials, case reviews, and reports of clinical interventions using therapeutic carbohydrate reduction exist. Reference 10:26-34. However, documentation of protocols indicating how clinicians may implement low-carbohydrate diets in hospital or outpatient settings to treat T2DM and related condition is underrepresented in the medical literature. I think I'm going to stop here today, or in this video. I'm going to make a follow-up video, of course. So this was the part 2 of the video series, and on the part 3, I'll start from the patient selection part or subsection. There are some problems. I was having a bit of throat issues while recording this video. I hope you will forgive my those noises, and I hope to see you in the next video. Take care. Bye-bye.